ladies and gentlemen. And it's time to proceed to the sharing from the next country, which is actually very exciting because the population from this country is huge, is massive. If you talk about this Southeast Asia region, I'd like to tell you that according to the World Bank, it has one of the biggest economy in this region in Southeast Asia, and more than 300 ethnic groups, ladies and gentlemen. That is big diversity that we would like to take all of ladies and gentlemen to take part in and learn more from the big picture of pharmacogenomics in this country, which is Indonesia. We are honored to have representative from Yazid University, which will be presenting on behalf of Dr. Riga Yuri Wulandari. Ladies and gentlemen, let's give it up to Miss Hilatus Zaro.
Discuss about the updates on pharmacogenomics education in medical schools in Indonesia. The rise of pharmacogenomics is evident from the growth of genomics technology and the use of multiple genes and variants to understand drug response. The table shows the number of citation index in PubMed that contains the word pharmacogenetics and or pharmacogenomics and normalized to the average number of total citation per decade in PubMed. There has been exponential increase in the number of published articles with the aforementioned keywords since the 1960s until now. On the other hand, similar keyword returns different results in Indonesia. This table gave us the glimpse on the lack of PGX research in Indonesia compared to global. Lack of PGX research leads to the lack of PGX implementation. One of the most significant barriers to implementing PGX into clinical workflows is related to the knowledge of clinicians regarding all steps of the process, from the potential impact of PGX-based medicine on patient outcomes to knowing which test to prescribe to understanding how to use the result of testings. The challenge with PGX education is twofold. The first challenge is related to educating currently practicing members of the healthcare team. The second challenge is integrating PGX education into standard curriculum across medical disciplines in order to prepare future practitioners. Structured PGX education has also been identified in a CFAMS article as one of the key elements for successful PGX implementation at the national level. In 2005, International Society on Pharmacogenomics or ISP released recommendations regarding pharmacogenomics education in medical, pharmaceutical, and health schools. We translated these recommendations into a survey of pharmacogenomics education in medical schools in Indonesia. Clearly, there is an urgent need of pharmacogenomics education in Indonesia. We need to assess current status of pharmacogenomic education in Indonesia in order to generate a recommendation at national level. The study cohort includes representative undergraduate medical schools in Indonesia with various accreditation levels and age of establishment. The majority has accreditation level of A and has been established for more than half a century. Question types were derived from ISP recommendations and previous articles on PGX education. Less than half respondents answered that PGX topics have been structurally taught. However, it was seldom taught as a standalone course, but most often part of pharmacology course. One to 2 hours is the most common duration for PGX teaching, which is still below the ISP recommendation, at least 4 hours or ideally 8 hours. The most frequently taught PGX biomarkers were CYP genes, such as CYP2D6 and CYP2C9. The majority of PGX teaching incorporates TDM concept, but not case study. The inclusion of case study is recommended in PGX teaching by ISP. A more adaptable and easily accessible educational tool is important to the successful delivery of PGX education to both students and practicing clinicians. The majority choose not just to use textbooks, but also original research and review articles and internet resources. The majority of respondents plan to incorporate PGX teaching in medical undergraduate school soon in 1 to 3 years. There are several feedbacks on PGX education from respondents. Those who are pro suggest to include PGX education in national curriculum, and then they feel that they need guidelines on how to incorporate PGX education in undergraduate medical school curriculum. They also feel that they need guidelines on teaching methods and research direction. Some also need to add more teaching hours of PGX in undergraduate medical schools, and they feel that they need to incorporate PGX education in pharmacogenomics syllabus and in national standard of Indonesian medical doctor competencies. On the contrary, some feel that PGX teaching is not suitable for medical students and could be a burden. According to national standard, they say, PGX teaching is only required as an introductory course for medical undergraduate students. PGX education is more suitable for postgraduate studies. In order to integrate structured PGX education in undergraduate medical program, we need to consider expected and required competencies from a medical doctor. The incorporation of PGX teaching should not be a burden for medical students or reduce time allocation for achieving much needed competencies. As for the current situation in Indonesia, PGX is not listed in National Standard of Indonesian Medical Doctor Competencies, and not all medical schools are willing to provide PGX education in their curriculum. The low number of PGX research and implementation in Indonesia can be attributed to lack of PGX education. To summarize, structured PGX education for future medical professionals in Indonesia, especially at undergraduate levels, are urgently needed. There's a need to change curriculum at national level and include PGX education in national standard of Indonesian medical doctor competencies. We suggest to incorporate PGX education plans in CFAM future working programs. Ongoing initiatives of PGX implementation have been launched globally. One of them is CFAM. It is important to create a structured PGX education and training to strengthen involved personnel and to ensure the sustainability and effectiveness of PGX implementation. The development of regional PGX educational resources may help speed up the capacity building process in Southeast Asia. Thank you for your attention. We are open to discussion.